Welcome, medical students. Let's get right into it. Today, we're acting as diagnostic detectives in this highly focused explainer. We're going to completely decode diarrhea using a super clear, dichotomous decision tree. As future docs, you already know GI distress is going to be your bread and butter. So rather than drowning in a sea of random symptoms, we're building a rock-solid, logical framework that's going to point you exactly where you need to go on the wards.
All right, so here's our roadmap, basically our diagnostic syllabus for the day. We'll hit 5 key steps: defining the condition, splitting acute versus chronic, comparing non-inflammatory and inflammatory mechanisms, spotting those crucial clinical features, and finally identifying the specific etiologies. Boom! Let's go.
Okay, step 1. Defining the condition. What actually is diarrhea, clinically speaking?
I absolutely love the organization of the medical notes we're using to guide us today. The flow is just fantastic. It takes this massive, broad concept and branches it out top-down into highly specific, actionable clinical pathways. Keep this mental map handy as we zoom into the weeds.
Now, the big takeaway here is that you absolutely need exact quantitative metrics to formally diagnose this. It's not just a patient saying, "Hey doc, my stomach's upset." You are looking for a stool weight of over 250 grams per day, but weight alone, not enough. It has to come with increased liquidity, meaning a real, distinct change in consistency, plus a frequency of 3 or more episodes a day. So remember those 3 pillars: weight, liquidity, frequency. That is your absolute baseline.
Moving on to Section 2, acute versus chronic, the all-important 2-week mark.
Listen, time is literally your most valuable diagnostic tool here. By splitting the timeline right at the 2-week mark, we instantly categorize the whole problem. If symptoms have been hitting for less than 2 weeks, bam, it's acute, which heavily points us straight toward infectious diarrhea. On the flip side, if this has been dragging on for more than 2 weeks, we've crossed into chronic territory, and that suggests an entirely different beast: malabsorptive syndrome. Now, for the rest of this explainer, we're following that first path and diving deep into acute infectious gastroenteritis.
All right, Section 3, non-inflammatory versus inflammatory. Let's look at the microscopic mechanisms.
So, at a cellular level, we essentially have 2 opposing forces at play. First up, we've got non-inflammatory infectious diarrhea. This is where a bug enters the GI tract, colonizes, multiplies, and then pumps out a toxin. It's that toxin that actually messes with the gut's ability to absorb. Think of it like surface-level chemical warfare, right? On the other hand, we have inflammatory diarrhea. The bug enters and multiplies, sure, but then it gets violent. It physically invades the gastrointestinal wall to cause actual inflammation and tissue destruction.
And while we're talking about the non-inflammatory side, we have to highlight a really crucial variant: food poisoning. In this specific scenario, the bug doesn't even need time to set up shop and multiply in the gut. Why? Because the patient just ingested a preformed toxin that was already chilling in their food. That means a super rapid onset. The weapon was loaded and fired before it even hit the stomach.
Let's hit Section 4, spotting the clinical features. What are the actual clinical signatures?
Going back to the medical notes we're referencing, you can see how perfectly these 2 microscopic mechanisms translate into 2 totally distinct clinical presentations on the ward. Visualizing this stark contrast is exactly how you want to structure your clinical reasoning.
You need to constantly contrast these in your head while taking a history. For non-inflammatory cases driven by toxins, you typically aren't going to see a fever. The patient will present with profuse watery diarrhea and watery vomiting, along with intermittent cramps. The fluid is literally just pouring out because absorption is blocked. Conversely, for inflammatory cases where the gut wall is actively under attack, you'll see systemic signs. We're talking fever, malaise, anorexia. The stools won't just be watery, they'll contain blood and mucus because of the actual physical tissue damage. And instead of intermittent cramps, patients will often complain of constant, severe abdominal pain.
Inflammatory diarrhea also brings along this highly specific and, let's be honest, incredibly uncomfortable symptom: tenesmus. This is that repeated, constant urge to defecate even when the bowels are completely empty. It is a massive red flag. It tells you the mucosal inflammation has traveled all the way down the GI tract and caused proctitis, inflammation of the rectum. If your patient mentions tenesmus, you are almost certainly hunting an invasive inflammatory pathogen.
Okay, final stretch. Section 5, identifying the etiologies. Time to name our culprits. Let's organize our viral and parasitic offenders using that exact same non-inflammatory versus inflammatory split. Looking at the viruses, rotavirus, which is the leading cause in kids, by the way, and Norwalk virus, both cause non-inflammatory watery diarrhea. But CMV, that one crosses into invasive, inflammatory damage. Moving over to parasites, Giardia lamblia and Cryptosporidium, with crypto being a major opportunistic infection in HIV and AIDS patients, sit squarely in the non-inflammatory camp. But Entamoeba histolytica, that one absolutely crosses the line and drives major inflammatory tissue destruction.
When we look at the non-inflammatory bacteria, we can categorize them by their exact modus operandi. First, we have the ones that produce enterotoxins once they're already inside the gut. Classic examples here are Vibrio cholera and enterotoxic E. coli. Yep, the infamous culprit behind travelers' diarrhea that ruins vacations all over the globe. Then we have the food poisoning category we touched on earlier, acting via those sneaky pre-formed toxins. If the sickness hits incredibly fast, like out of nowhere, you should immediately be thinking of Staphylococcus aureus, Clostridium perfringens, or Bacillus cereus.
On the flip side, our inflammatory bacteria are the heavy hitters, actively invading tissue, causing those fevers and bloody, mucus-filled stools. The enteroinvasive gang includes Salmonella, Shigella, enteroinvasive E. coli, Campylobacter jejuni, and Yersinia enterocolitica. We've also got bacteria that produce deeply damaging cytotoxins. Crucially, C. diff is a notorious one here. It often pops up as a side effect of broad-spectrum antibiotics, leading to pseudomembranous colitis. It's a really severe inflammatory response that you absolutely must watch out for. To wrap up this explainer, I want to leave you with a provocative thought for your clinical practice. How does knowing whether you're fighting a surface-level toxin or a deep tissue invasion completely change your approach to patient management? Really think about it. Are you just rehydrating a patient who's losing water to a surface enterotoxin? Or do you need to aggressively step in with targeted antimicrobials for an invasive pathogen that's actively destroying the gut wall? Understanding this tree isn't just an exercise in rote memorization. It's literally the foundation of how you are going to save your patients' lives. Keep this diagnostic map in your back pocket and you will always know exactly where you stand. Thanks for joining me and keep learning.